about diuretics in this class. The term diuretic is an agent that increases the urine volume. Natriuretic refers to those agents which increase the renal sodium excretion, and aquaretic means those substances which increase the excretion of solute-free water. So here we are going to see about diuretics, which increase the urine volume mainly by increasing the renal sodium excretion. Before going to the drugs proper, we shall have a quick review about the physiology of renal tubule transport mechanism. So this is the nephron, proximal convoluted tubule, the loop of Henle, distal tubule, and the collecting duct. Most of the sodium, bicarbonate, potassium, water reabsorption, and also reabsorption of glucose, amino acids, phosphates, and organic anions take place in the proximal convoluted tubule. And the thick ascending loop is the site where the salt reabsorption occurs, which contributes to the medullary hypertonicity, which contributes to the countercurrent mechanism, which we will see later. And distal convoluted tubule is the site again where it is the site of absorption of sodium reabsorption, and collecting duct is the site where the ADH acts to promote water reabsorption, and also aldosterone acts to increase the sodium reabsorption and potassium excretion. So as we know, the thick ascending loop and the distal tubule both are completely impermeable to water. This is proximal tubule where most of the sodium and bicarbonate reabsorption occurs. So here sodium reabsorption occurs through this sodium H plus ion antipode. So sodium gets inside and H plus ion comes out of the lumen cell, and this is the lumen, this is the interstitial blood, and this is the lumen cell. Okay, so this H plus ion which comes out, it combines with the bicarbonate to form carbonic acid, which again splits into carbon dioxide and water with the action of carbonic anhydrase enzyme. So this carbon dioxide again gets inside, gets reabsorbed back, again converted into carbonic acid with the presence of same enzyme, then splits back into bicarbonate and H plus ions, and this bicarbonate gets reabsorbed into the blood. And similarly, the sodium which reabsorbed here, it gets inside the blood through the sodium potassium ATPase. So this is the luminal membrane of the cell, and this is the basolateral membrane of the cell. Okay, so this reabsorption of this sodium, it creates a increase in the negative potential in the lumen. So this causes increased chloride reabsorption as well. So together sodium chloride both gets reabsorbed into the cell, and this is the sodium glucose symport. Okay, so this glucose and sodium together gets reabsorbed here. This is the ion transport pathway in the thick ascending limb. We have sodium potassium 2-chloride transporter in the luminal membrane, through which sodium, potassium and chloride reabsorption occurs. So here the potassium comes through this transporter and also through the sodium potassium ATPase, which is present in the basolateral membrane. So this excess potassium, this excess potassium comes out of the cell through the potassium transporter which is present here. So this creates increase in the positive electric potential in the lumen. So in order to maintain the neutral electric potential, more cations like magnesium and calcium, it gets passively reabsorbed through the luminal membrane. Okay, so in the thick ascending limb, sodium, potassium, chloride ions along with calcium and magnesium reabsorption occurs. And this is the distal convoluted tubule ion transport pathway. So here you have a sodium chloride transporter through which the sodium reabsorption occurs. And here the calcium, since sodium and chloride, one cation, one anion, so both are reabsorbed, there is no, it is electrically neutral. Okay, so this transport is electrically neutral. So here the calcium reabsorption is not passive, but rather the calcium is reabsorbed through active transport, transport mechanism, which is aided by the parathormone. Okay, this is the collecting tubule and collecting duct. You have principal cells and intercalated cells. The principal cell has epithelial sodium channel, ENaC channels which cause sodium reabsorption and potassium excretion. This is regulated by aldosterone. So more sodium enters into the collecting duct, more will be reabsorbed. So this entirely depends upon the activation of the channel, entirely depends upon the sodium load which is present in the urine when it reaches the collecting duct. And similarly, the intercalated cell, it has a H plus ion transporter which secretes the H plus ions into the lumen. So this is the site where sodium reabsorption is regulated by aldosterone, and also this is the site where H plus ions get secreted, which acidifies the urine. And this is the site of water reabsorption. You can see here, these are the aquaphorins. This is water reabsorption channels, and this is the V2 receptor, vasopressin receptor, through which antidiuretic hormone acts. Okay, so in the absence of ADH, these aquaphorins are not inserted into the apical membrane, so water reabsorption is very minimal. But in the presence of ADH, so more aquaphorins are inserted, which increases the water reabsorption. This is the countercurrent mechanism which happens in the medullary interstitium by the loop of Henle. Okay, so this is the descending loop of Henle and this is the ascending loop. We know that water permeability is there in the descending loop, whereas ascending limb is not permeable to water. This is the site where the reabsorption of solute happens, as we saw earlier. The reabsorption of sodium, potassium and chloride occurs here. This reabsorption of the solute, it creates increased osmolarity in the medullary interstitium, which drives the water out of the descending loop of Henle. So the water reabsorption or the increase in the water permeability through the descending lip is mainly because of the medullary hyperosmolarity, which is created by the solute reabsorption in the ascending loop of Henle. This is macula densa. This is the site where it senses the sodium concentration in the thick ascending loop of Henle, and depending upon the sodium concentration, it regulates the renal blood flow and the renin secretion. So this is formed by the afferent arteriole here, and this is the distal thick ascending loop of Henle, and these are the macula densa cells. This is the smooth muscle cells and renin secreting cells which are present here. So whenever there is increase in the tubular sodium concentration, this sodium, it gets into the inside the macula densa cell through the sodium potassium chloride transporter, which is present in the ascending loop of Henle. So this sodium is increased sodium is sensed by the macula densa cell, so which in turn causes adenosine mediated vasoconstriction of the afferent arteriole. Okay, so increased sodium means again increased urine volume. Okay, so this will be compensated by vasoconstriction of the afferent arteriole. And similarly, whenever there is decreased tubular sodium concentration, again these macula densa cell will mediate prostaglandin E2 mediated vasodilatation and increase in the renal blood flow, and also renin release, which causes increase in the sodium reabsorption. So till now we had a brief overview about the renal physiology of tubular transport mechanism. We'll move on to the drugs now. Diuretics are classified into high ceiling diuretics, which inhibits the sodium potassium 2 chloride co-transport. We have medium efficacy diuretics, which inhibits the sodium chloride import in the distal tubule, and we have some weak and adjunctive diuretics. So in this class we will see about high ceiling diuretics and medium efficacy diuretics. Loop diuretics or high ceiling diuretics are the most efficacious diuretic agents. They are called as loop diuretics because they act at the thick ascending loop of Henle, and they are called as high ceiling because they have very steep dose response curve. Okay, so increase in the dose cause increased diuretic action with minimal or no ceiling effect. So even it can produce up to 10 liters of urine. So that is why they call us high ceiling diuretics. and it inhibits the sodium potassium 2 chloride transporter at the thick ascending loop of Henle. And this is the relative potency of loop diuretics. So you have drugs like furosemide, torsemide, bumetanide, and ethacrynic acid. So here you can see bumetanide is the highly potent loop diuretic, followed by torsemide and then furosemide. The site of action of loop diuretics is in the thick ascending loop of Henle. It blocks the sodium potassium 2 chloride transporter, thereby inhibiting the reabsorption of sodium chloride and potassium. So by inhibiting this, it also inhibits the passive reabsorption of calcium and magnesium as well. The major site of action, as we saw, it is the thick ascending limb, and the furosemide, it is secreted into the tubular fluid through the organic acid pathway. Okay, so it gets secreted through the organic acid transporter in the proximal convoluted tubule, and then it reaches the ascending loop of Henle through the tubular fluid. Then it acts from the luminal side. And there is a minor component of action on proximal tubule also, and it has a weak carbonic anhydrase inhibition action also. And apart from that, it causes venodilatation, which causes increase in the systemic venous resistance, and also increases the prostaglandin E2 synthesis, thereby increasing the renal blood flow. And it increases the calcium and magnesium excretion, because of the reason we saw earlier. And it raises the blood uric acid level by competing with the tubular secretion. So you all know uric acid is secreted in the proximal convoluted tubule. So this furosemide competes with the uric acid secretion. It also inhibits the uric acid reabsorption. So together it increases the serum uric acid level. Bioavailability of furosemide is 60%, and this bioavailability is further reduced in cases of severe congestive heart failure because of the intestinal wall edema. The plasma half-life averages 1 to 2 hours, and it has very low lipid solubility, and it's highly bound to plasma proteins, and it is conjugated with glucuronic acid and excreted unchanged by glomerular filtration and tubular secretion. The uses of high ceiling diuretics. They are mainly used in all kinds of edema, cardiac, hepatic, and renal edema, and it is especially helpful in acute pulmonary edema due to acute left ventricular failure following myocardial infarction. So, because of its additional venodilatation, okay, because of its additional effect on increasing the systemic venous capacitance, and it is used in cerebral edema in combination with osmotic diuretics. In hypertension, it is used whenever there is coexistent renal insufficiency or heart failure, or in cases resistant cases of hypertension, loop diuretics are used. Otherwise, thiazides are first choice of diuretic in hypertension. And to prevent volume overload during blood transfusion in cases of anemic patients, you can use loop diuretics along with blood transfusion. And along with hypertonic saline, it is used in the treatment of hyponatremia to prevent volume overload. And hypercalcemia of malignancy is a medical emergency which presents with severe, volume contraction. So in those cases, IV saline infusion is given, and loop diuretics is given along with saline infusion in order to hasten the calcium excretion. And we'll move on to thiazide diuretics. So these are medium efficacy diuretics, and it is secreted into tubular fluid via organic acid pathway, just like the loop diuretics. And the site of action is the early distal tubule, and it inhibits the sodium chloride symport at the luminal membrane. It has additional carbonic anhydrase activities also like loop diuretics, and it reduces GFR, and hence it is not used in renal failure. Whenever the GFR, when the GFR becomes less than 30, then loop thiazides cannot be used, and it decreases the calcium excretion. It again, like loop diuretics, it competes with the uric acid for the transporter and causes uric acid retention. The site of action of thiazides, so it is in the distal convoluted tubule, it blocks the sodium chloride's import, thereby decreasing the reabsorption of sodium and chloride. They are well absorbed orally, and it is metabolized very little, and it is excreted unchanged through kidney. Uses of thiazides are mainly in cases of edema. Mostly thiazides are used for maintenance therapy. So for severe edema, loop diuretics are preferred drugs of choice, and thiazides are used only for mild to moderate cases and for maintenance. And thiazides are first choice of diuretics in the management of hypertension, and it is used in diabetes insipidus and hypercalciuria. Okay, because it decreases the calcium excretion. Adverse effects of high ceiling and thiazide diuretics are mainly hypokalemia. So we all know sodium reabsorption is inhibited by these diuretics. So more sodium will be delivered to the collecting duct. So that means more sodium will be reabsorbed through the epithelial sodium channel under the regulation of aldosterone action. So which means more potassium secretion. So this leads to hypokalemia, and it may cause acute saline depletion because of decreased sodium reabsorption. Dilutional hyponatremia can occur because of compensatory increase in the water reabsorption without adequate salt reabsorption. So this may lead to dilutional hyponatremia. Gastrointestinal disturbances like nausea, vomiting can occur, and CNS disturbances like headache, confusion and dizziness can occur. Hearing loss is due to disturbance in the electrolyte balance in the endolymph, and also due to damage to the hair cells. Allergic manifestations can occur. Hyperuricemia is due to inhibiting the organic anion transporter. Okay, so both these diuretics and uric acid compete for the same transporter for the secretion. So this may lead to increase in the serum uric acid level, and also because of decreased reabsorption of uric acid. And hyperglycemia can occur due to inhibition of insulin secretion because of hypokalemia, and dyslipidemia in the form of raised serum cholesterol and triglycerides can be seen. And hypocalcemia and magnesium depletion occurs especially with the loop diuretics because of decreased passive reabsorption of calcium and magnesium in the thick ascending limb. Caution and contraindications with the use of diuretics. So diuretics are used with extreme caution in patients with cirrhosis because it may induce mental disturbances and precipitate hepatic coma because of associated hypokalemia. So hypokalemia can lead to alkalosis, which may inhibit the formation of urea from ammonia. So more ammonia will enter into the brain, which may lead to mental disturbances. And toxemia of pregnancy is a condition where there will be edema, but in spite of the edema, the ECF volume will be very low. So if you use diuretics in toxemia of pregnancy, so the uteroplacental flow will be disrupted, or it will be compromised. So diuretics are not used in toxemia of pregnancy. Interactions of diuretic with other drugs. Diuretics potentiate all antihypertensives because of the synergistic action. Because of hypokalemia, diuretics can enhance digoxin toxicity. So we all know hypokalemia enhances digoxin toxicity because both potassium and digoxin competes for the same receptor. So less potassium means more digoxin will bind to the receptor, and it increases the risk of arrhythmia due to drugs which prolong QT interval, again because of hypokalemia. And it reduces sulfonylurea action. These are drug interaction because of hypokalemia. And concurrent use of diuretics with aminoglycosides may increase the risk of ototoxicity and nephrotoxicity. And NSAIDs diminish the action of high ceiling diuretics because of the inhibition of prostaglandin synthesis. So we all know loop diuretics or high ceiling diuretics have an action of increasing the prostaglandin secretion, thereby increasing the renal blood flow. So which is an important mechanism of action of furosemide apart from the action in the thick ascending limb. Okay, so NSAIDs will diminish the action. And probenecid, which is an uricosuric drug, it inhibits the tubular secretion of furosemide because it inhibits the organic anion transporter. So it inhibits the tubular secretion of furosemide and thiazides, thereby decreasing the action. Resistance to diuretics can happen after prolonged administration. It can be due to the following reasons. Due to renal insufficiency, because renal insufficiency may lead to low GFR, which again leads to less secretion of diuretics and less action. In congestive heart failure, there will be impaired oral absorption because of mucosal edema, and also there will be decreased renal blood flow, which may lead to decrease in the efficacy of diuretics. In cirrhosis liver, there will be raised aldosterone level, which will counter the action of diuretics in sodium reabsorption. In nephrotic syndrome, the diuretics will bind to the urinary protein which are excreted, and this may lead to decreased action, and also there will be raised aldosterone level in nephrotic syndrome. And concurrent NSAID administration will counteract or will diminish the efficacy of diuretics. Diuretic resistance can be managed by the following steps. So, increase bed rest because it will increase the renal blood flow. Increase in the dose of loop diuretics can be tried because loop diuretics have high sealing effect, so dose can be increased. And smaller, more frequent administration or continuous intravenous infusion of loop diuretic can be helpful because it makes the diuretic more available in the active site for a prolonged period. And use of combination therapy to sequentially block more than one site in the nephron can be tried. For example, combining a loop diuretic with a potassium sparing diuretic, or thiazide diuretic with a potassium sparing diuretic, and reducing the salt intake. So this will decrease the compensatory increase in the sodium reabsorption post diuretic action. After diuretic action subsides, there will be compensatory increase in the sodium reabsorption. So this can be minimized by reducing the salt intake, and scheduling the diuretic administration shortly before food, so that the peak diuretic action can be can be there whenever there is increase in the salt load. So by following these steps, diuretic resistance can be overcome. We shall see about the remaining diuretics in the next class. Thank you.